Wonderful. Hello, everyone. Thank you for attending today's discussion From Ideas to Action, Blueprints to Advance Health for All. I'm Ryan Panchadsaram, advisor to the chairman at Kleiner Perkins, a pre-Allies advisor, as well as former Deputy Chief Technology Officer for the United States. I'm so happy to have you today with us, and I'll be moderating this webinar. I've got a few first technical notes before we begin. The discussion is being recorded and is going to be available on demand within a few days after the event. So we'll send you an email when it's available. Please submit any questions using the Q&A chat. We're going to be monitoring that and saving a good portion of the end of this webinar to answer as many questions live as possible. If you encounter any technical problems during the event, drop something into the Q&A and we'll help you out as well. The panelists who are going to be introducing themselves in a moment are joining us to discuss how health inequities are contributing to the findings from Pre-Allies' latest report, the 2022 State of Health, which in the report, it identifies the conditions that are most at risk of increased healthcare utilization this year. Pre-Allies Health is a healthcare exclusive predictive analytics company, and the report's findings are based on our analysis of claims data for more than 2 million members between September 2017 and August 2021. The 2022 predictions include a 22% increase in the healthcare utilization for individuals with musculoskeletal conditions, a 17% increase in the utilization for individuals with diabetes, a 14% increase in obesity, a 9% increase in under 18 mental health care utilization, and a 4% increase in substance use. The report also includes the drivers for these increases, from delayed care to deteriorating behavioral health because of anxiety, depression, and alcohol use, to the overall wellness decline from stress, overeating, and weight gain. This pandemic spared no one. I do encourage folks to dig into the report. It's just 11 pages and full of insights and actionable information. So let's get started with introductions. Let's see, which way to start first? Can folks share a bit about your background, where you're at today, and how equity features in your work? Maybe let's start with you, Mark.
My name is Mark Smith. I'm a general internist and HIV doc. Spent 22 years in philanthropy at the Kaiser Family Foundation, the California Healthcare Foundation, and now continue to see patients and serve on a number of boards, including that of Pre-Allies.
Thank you, Mark. Linda. I think you're on mute.
The classic, right? Hi, Linda Han, CEO of Pre-Allies Health. Thank you all for joining us. I joined Pre-Allies in 2018. I've had a long career in Silicon Valley high tech. I've created software solutions for a number of different challenges across different verticals. But just prior to Pre-Allies, I spent 16 years in the life sciences clinical trials software space, where my awareness of inequities in drug development and testing were sort of heightened. So, you know, the last few years, really, the activities and issues that have kind of highlighted how this has come to play in healthcare. I'm really grateful to be at Pre-Allies, where we're seeing customers and good momentum in the market to address these issues. And so partnering with customers to understand bias, help them develop ethical AI programs, and most importantly, use these types of insights to address this for their communities.
Thank you, Linda. Rishi?
Hi, everybody, and great to join you guys. I'm Rishi Manchanda. I'm CEO at Health Begins. I'm a primary care trained physician and have been working through my work at Health Begins and in prior work focused specifically on health equity and more specifically on the social and structural drivers of health equity, social risk factors included. And so through my work at Health Begins and through the work with a lot of clients and partners, we get to think about how to take descriptive and predictive analytics and think a bit more intently about what social risk looks like and how we can be more aware of them, if not try to address them. And that's a little bit of what I'm able to bring. I'm trying to bring, at least as part of my advisory role at Pre-Allies as well. So pleasure to join you guys today.
Thank you, Rishi. Ron?
Hey, everyone. I'm also, like Mark and Rishi, a physician, although my wife's pretty clear, you're not a real doctor anymore, don't touch the kids. So it's been a while. I've been on the leadership side. Most recently, spent 15 years running health systems at Geisinger and Mission Health in North Carolina. More recently, I've been an executive in residence with the venture capital firm General Catalyst. And it was really both, frankly, my own childhood growing up in a poor rural community and seeing our own challenges accessing care, but then more importantly, as the CEO in North Carolina, where we were part of Southern Appalachia and all of the incredible challenges that go along with folks that are poorer or culturally different, and how those things impact their ability to receive and access and benefit from care, that really has made this a motivating feature for me.
Thank you, Ron. Linda, Mark, Ron, Rishi, I'm so glad to have this conversation with you. We're going to start digging into questions. And as I shared a bit earlier in the report, right, there were key findings that said that 22% there will be a predicted increase in utilization with folks that have musculoskeletal conditions, 17% for individuals with diabetes, and 14% with individuals that have obesity. And it's well documented that Black and Brown individuals are at higher risk for most of these conditions than white individuals in America. And that's not because they're less healthy people. And let's talk about why. What role does our healthcare system play in these health disparities? And what responsibility do healthcare leaders hold in creating and maintaining equity? Ron, you were last introduced, so maybe I might pick on you first.
Sure. And you know, I mentioned having been a health system CEO, and that's the most coloring that I've had of my perspective on this. And in that role, I've witnessed firsthand some of the access challenges that impact so many people of color, and really poor individuals of any ethnicity, background, or color. And there's a lot of different barriers, you know, including lack of insurance or lack of access to quote unquote good insurance, a lack of culturally appropriate and competent outreach. We know that how people want to receive care and the language that they use and respond to and relate to can be quite different. And then there's all of the things that we now sort of globally refer to as so-called social determinants, the environment and associated conditions where people live, learn, work, and play. And so I got to be honest, you know, what I saw and what I strove relentlessly to try to impact was this two-tiered health system, right? Those with and those without. When you think about where health systems place their new facilities and the segments that they're trying to impact, it often doesn't come from this equity social improvement lens, but something that's related to keeping the doors open and generating margin that too often shows up in orthopedics and those kinds of things. So it's a really important thing.
Mark?
So obviously in the last couple of years, you've seen an enormous rise, I think, in the consciousness about and the commitment to work on equity in the healthcare system. Virtually every system, every organization now has an equity focus, a DEI officer, a chief equity officer. And I think the reasons for that in part stem from the outpouring of opposition to inequity that happened after the murder of George Floyd and the kind of spontaneous uprising around the country. But also, if you look at the number of academic publications on social determinants of health in the last decade, it's exploded. And so I think, as Ron said, everyone in healthcare now has to be aware of the fact that there are so many circumstances around people's other life circumstances that impact their ability to access the healthcare system, the way in which they're treated when they get there. All those sorts of issues have a tremendous bearing on health, frankly, often more than the healthcare system itself. And so I think everybody in healthcare has got this consciousness. I think it's important always to put equity in the context of quality of care and not separate it, because you know, there's great difference in our country around the issue of social justice. And while equity is certainly an issue of social justice, it is, and I think should also be an issue of professional responsibility. So I think it's important to put equity squarely in the context of quality as people consider where their priorities are and where they put resources.
It's a measurable place. Rishi?
Yeah, just to build on Mark's point and Ron's earlier point as well, I think it's certainly clear that more and more in healthcare, understanding the importance of equity, if not for the broader understanding of what equity means in society, if at the very least, because it has implications for what payers and regulators are now asking for in terms of understanding, identifying inequities that exist, especially racial inequities in access and treatment and in quality, in particular to Mark's point. So I think more and more in healthcare are recognizing that this is that equity has to be at the center. Now, for many of us who've always recognized that and have been promoting that, what is welcome about this opportunity is to then bring forward more rigor, more concrete kind of opportunities to really advance that understanding into action. That means understanding that what equity means, and then also understanding that there are social and structural drivers of equity. And so a lot of the work in the last decade in particular, as Ron and Mark spoke to, is this understanding of social determinants of health. Right now, a lot of folks that we talk to in healthcare just aren't yet connecting the dots between the social determinants of health work they've been doing, a farmer's market, about screening for food insecurity, and then equity. What we, I think, have an opportunity to do is to have folks now fully recognize that the work of social determinants is very much part of, along with quality and safety work inside the wheelhouse of healthcare, is about understanding what the social and structural drivers of health equity are. That has very specific implications for how we can be better at quality and safety, how we can be better at population health management, how we can be better at care coordination, and how we can be better at community benefits or community health kind of initiatives, where healthcare obviously has a big role as well. The question is, how can we be better? And equity now is finally front and center in people's analysis of answering that question. And I'm looking forward to today's conversation to think about how data can play a role in that.
Linda.
Yeah, hard to follow those acts. I mean, communities of color typically had higher uninsurance rates, lack of affordable coverage, eligibility restrictions we haven't even talked about in terms of immigration status. But 80% of health or lack thereof happens outside of the healthcare system. So, you know, I think one of you mentioned, you know, where we live, who we live with, what we do for a living, whether we have reliable, healthy food or stable incomes. And that's so many of the factors that communities of color often struggle with. So, you know, treating the whole person and their circumstances in the context of their healthcare is really a moral and business imperative for healthcare leaders.
And so the pandemic itself, I'm very curious to hear from each of you. How did it exacerbate the inequities that you're seeing? Mark, I know we've talked about this before. What did COVID do to our healthcare system, and why did it lead to these disparities?
Well, first, I think from the early days of the epidemic, it was apparent that some people were more likely to get infected, more likely to get hospitalized, more likely to die than others. And the first kind of explanation of that, particularly from the lay press, was pre-existing conditions. Now, the problem with that was, of course, people rarely went further to say, as Rishi would say, well, why did they have pre-existing conditions? Why did they have more diabetes? Why did they have more? So that's the first question. But it then became clear that it wasn't just their pre-existing health conditions. It had to do with whether or not they could work from home, whether or not they were working in crowded meat plants and agricultural settings, whether or not they were more likely to live in multi-generational households where you couldn't be isolated if you got infected. All of these other issues that we've been talking about that really happened outside the healthcare system had a direct impact on people's likelihood of getting infected. And then whether or not you had insurance, which might determine whether or not you sought care or how early you sought it, where you sought care and the resources that were available in those settings, and how you got treated, whether someone intubated you or sent you home. All of those issues, again, played in. So all of these issues that happened outside of healthcare that led to the likelihood of being infected, the likelihood of getting sick, were compounded by the inequities in the healthcare system itself.
And when you look at that data, right, you look at data across multiple lenses, the disparities are there in hospitalizations, in deaths, in vaccination rates, in masks. And I'd love to unpack from each of your perspectives the why behind that. Maybe Ron, I might start with you on that.
Yeah, I think to Mark's comments, right? COVID didn't cause any of these things. It revealed them. So it was like an opaque window now became clear, and you could see all of this impact that was occurring throughout the United States environment. So in LA, where I live currently, this issue of multi-generational family households and square footage of household environments and the likelihood of transmissibility within the Hispanic community in particular was one that dramatically accelerated the infection rate, compared to others. Similarly, we know that people will withhold from themselves even really important care if they don't have insurance and don't have the money to pay for it. So delayed time to presentation. So my biggest takeaway is we might have been hiding behind these quote inequities for a long period of time. It's now so front and center that I hope that this is the impetus that we all needed to really put this at the fore of our activities.
Rishi, I saw you unmute.
Yeah, I want to do a +1, but I also know, Linda, do you want to, I'll defer.
Well, I was just going to bring a few statistics to the table. I got some stuff from the CDC, and I thought maybe I would highlight kind of the inequities a little bit, if you might. I'll humor me for a minute here. CDC reports that Blacks made up 30% of COVID cases, though comprise less than 13% of the population. Hispanics and Latinos over 4 times more likely to be hospitalized and almost 3 times more likely to die from COVID than non-Hispanic whites. And American Indians and Alaskan Natives contracted COVID 3.5 times higher than whites in the first 7 months of the pandemic. And again, they cite that people of color are likely to have underlying health conditions, putting them at higher risk, more likely to have limited access to COVID testing and treatment, which is another key thing. And then again, the living conditions, housing situations, all of that really kind of exacerbated this. Go ahead, Rishi.
Yeah, I think that data was actually really helpful just to underscore something that I think COVID really revealed for a lot of folks. Sorry for the barking dog in the background. There's 2 things about this. Apparently you can hear him pretty well. So 2 things. One is I think there has always been a recognition that there are disparities, which are essentially just differences in certain health status rates between population groups. And for the longest time, we in healthcare have long been just defining and categorizing disparities. But what COVID revealed is that there are inequities, which are some disparities that are unjust and unfair. And then the question is, well, why are they unfair and unjust? And I think what COVID revealed is that it's not that the mental model that we've long kind of let reign over all of us is a downstream model that just doesn't make sense. COVID just blew through it. So for the way I kind of communicate this, and I've been talking about it for some time, is through the age-old kind of story of, give a man a fish, teach a man a fish, right? It's the old adage that we all go by. It's something that has become almost like deeply embedded in our DNA as we think about what the world needs to look like. Oh yeah, don't give a man a fish, teach a man to fish. What COVID revealed is, well, why not teach a woman to fish? What if the pond is polluted? What if he and his family have been historically denied access to the permit to fish, the rods, the tackle, the ability to actually go or even take the fish and sell it in the market? The point is, we have long been letting reifying this kind of mental model that assumes that it's about behavior and about certain demographic attributes and not about the structures. And COVID just revealed that it's about the structural analysis. It's about, you have to understand that these structures are not esoteric kind of academic concepts. This is life and death. And the stats just reveal that in ways that hopefully are not numbing, but hopefully are compelling, right? To educate us that when somebody is unnecessarily dying now because of COVID, because of where they live, where they work, it's not that they made a choice to put themselves at risk for living in a food desert or having a bad job or having no insurance. It's that there are certain determinants. So food insecurity, for example, of an individual risk. Somebody who's food insecure probably lives in a food desert, but that food desert isn't there by accident. It's because of redlining and historic influences that are still playing out to this day that influence where food deserts exist. COVID made it clear that more of us need to have a structural understanding of things rather than just a downstream, simplistic understanding of what drives health, or for that matter, equity.
Mark, how does this tie to the point you shared earlier on quality? I feel like it really does. Would love to hear just your point of view on this.
So, 20 years ago, the Institute of Medicine developed this rubric for quality, which I think most people accept, try to divide it as six domains: quality means that healthcare should be safe, effective, efficient, timely, patient-centered, and equitable. And the fact of the matter is that often those domains will be in some tension or contradiction with each other. One can imagine operating room procedures which are efficient but unsafe, right? One can imagine prescribing patterns, say horse dewormer for COVID, that may be patient-centered but ineffective, right? And one can also imagine well-meaning efforts to be timely or efficient that, looked at from an equity standpoint, actually make inequities worse. So that's why people, I think, use this term of an equity lens. Doesn't mean it trumps the other dimensions of quality, but it means if you don't take it into account, if you don't account for it along with efficiency and timeliness and patient-centeredness, you won't be addressing the problem in an integrated way. So that's how I always approach this. And as a colleague of mine said, it doesn't matter what you do in healthcare, whatever your most important quality metric is. If you are in radiation oncology or pediatric nephrology or an operating room supervisor, take your most important quality metric and then analyze it by race, by sex, by principal language, and you will find something to go to work on. You don't need to wait on kind of big academic papers. We know where the axes of inequity are. And if one looks at whatever is most important to you in terms of quality, you are likely to find that people don't have the same outcomes, people don't have the same results. And that, I think, provides people with a good starting point to go to work on this, as Rishi said, in practical kind of non-academic ways.
Yeah, I'd love to build on that, in particular, drill down on the patient-centered component, which Rishi and Mark are pointing out structural issues, right? Mark, you've said, I have this embedded in my memory, this sort of structural approach is a feature, not a bug of the system. It's designed in. And one of those things that are way too often designed in is not providing a holistic, integrated, culturally sensitive and appropriate approach to populations of people and communities. And in the absence of a conscious effort to deliver culturally appropriate and competent care, most of us default to the typical mainstream American, predominantly white medical view of the world. And you see this over and over again on numerous groups, including Native Americans, Native Hawaiians, where I've been spending some time, and many other minority and marginalized communities. So people want to receive care from people who understand them and appreciate them and listen to them, sometimes who look like them. And you can't just have this medical only, here's your diagnosis, here's your drug perspective. It has to be holistic and integrated. Some cultures like to involve the family, others not so much. And so again, with COVID, this is pointed out so clearly as just one sad and tragically obvious example, the tailoring messages to different constituencies being so critical and is just almost lacking in our vaccine debate, so to speak. And although obviously I think everyone should be vaccinated and get vaccinated, not just for COVID, but for all of the preventable illnesses, I don't know how anyone could believe that telling people that they're stupid, ignorant, or bad Americans is going to get them and motivate them to want to get vaccinated. We've got to find ways to build bridges, and it's really about trust. And you can't build trust without that focused, holistic perspective.
One of my takeaways from this crisis is that, the messaging that we produce around public health is so powerful and important. And a part of it, I think, is trusting that we can give people all the facts and science and pieces behind our recommendations. I think there's something around really trusting the public with, why different public health institutions are making the certain kind of recommendations that they are. But that's a tangent point. Maybe the bigger takeaway from this conversation is to echo what Mark shared, which is in any of the work that we do, if it's particularly on the lens of COVID or in any part of our health system working piece, is identify the measure that matters, right? The measure that you're currently thinking that we're doing a great job at. And if you slice it by demographic or background, you're going to very quickly to see where you need to go to action. And so that advice is really tangible. I'm going to shift over to Mark.
Averages are our enemy, right? If we are satisfied with the fact that 85% of something happens and don't figure out that it's 96% in one group and 43% in the other, averages are our enemy. That's why it's important to stratify these things.
It makes you ask the question on all the measures that matter, can you double click into them? Right? Because if the averages are the enemy and I can't see inside, that's kind of putting blinders on to a problem. I'm going to shift our conversation toward mental health, because in the report, last year's report highlighted that we are in the midst of a behavioral and mental health crisis, and it only continues to get worse. In this most recent report, it talks about that increase, almost 10% in the young adult population in healthcare utilization around mental health needs, as well as just an overall increase across adults as well. And so as payers and providers work to address this issue, what are some of the critical considerations? Rishi, I would love to start with you.
Well, I think from a really concrete perspective, starting with and reinforcing what Mark and you summarized so nicely, it starts first, if it's mental health and well-being, how do we identify the measures that matter here? It may be the time to diagnosis. It may be the ability to, it's post-discharge follow-up with a primary care or a mental health provider. There are a variety of performance measures that have direct relevance to behavioral health, including behavioral health integration in care settings. Identifying those measures is key. A related one that I know Mark works on a lot is just also how to make sure in parallel you're increasing the collection of this information, because it's hard to stratify when there's very limited information on race, ethnicity, and data. And so improving data collection efforts is a fundamental step. But as you take, just building on those steps, identifying and stratifying your measures by race, ethnicity, and primary language, and identifying if there are inequities makes a lot of sense. The next set of steps as you get to work, as a team, especially from a quality improvement perspective, is, well, what are the root causes of those things? And quality improvement, whether it's adverse event reporting, teams, the folks who try to review in quality and safety rounds what's happening in terms of opportunities for improvement, fishbone diagrams and root cause analyses are part and parcel of what we do, right, in healthcare systems. What's interesting here is the opportunity, for example, for mental health to start to say, well, what are the drivers, what are the fishbone diagram kind of explainers of that, and to start to build on top of that to say, well, in addition to individual characteristics or institutional practices, right, that we might be responsible for, or staff performance or behavior, what are some of the social and also what are some of the structural root causes that may be explaining this adverse event or this outcome for mental health? For example, it might mean looking at the research, the emerging mountains of research that indicate that alongside individual level characteristics, there are also community level characteristics that are strongly correlated with mental health. For example, exposure to violence at a neighborhood level has been strongly linked to the incidence and prevalence of depression in communities. And for example, all the research that has been done about exposure to violence, including police violence in communities, has been linked through research studies to increased rates of depression and poor mental health days, particularly among Black residents of communities. There's research, right, data that allows us to start to think about some of the community level conditions, including exposure to violence, including the access to various resources in the community, access to psychologists and providers. Those are structural reasons that we can start to get better at. And the challenge that I see a lot of times for this approach is that most often in healthcare these days, we don't know so much about those social and structural causes. And so we kind of put them to the side. The way to solve for that is to expand the definition of the team. When going through an analysis of social and structural drivers, bring in folks who actually have that expertise, folks who work in the community health workers, social workers, et cetera, to expand the competency of the team to be able to identify social and structural drivers, in this case for mental health. That's fundamentally important.
We've always seen pain, depression, anxiety, behavioral health issues coupled with chronic conditions in our predictions, and most often as drivers of escalation in future cost. So even before the pandemic exacerbated, we had already doubled down on our machine learning investments in this space, to really predict behavioral health issues before a diagnosis hits the claim. And to Rishi's point, like to enable our customers to, help their members get ahead of it. We've also seen a rise in including mental health care in the team care approach and treating the whole person. So like bringing the medical, mental, community, and social resources together. So this suite of predictive analytics becomes very informative to that team care approach. And then, the stigma around mental health is real. And I think including it in this kind of team approach also can, make it more of a natural component of care and lessen that stigma. I did want to, Ryan, you mentioned the under 18, and I wanted to touch on that increase. We had a webinar a few weeks ago on the topic, and there were several key points made by the panelists there. First of all, virtual health doesn't really work well for youth and teens in particular. One, they need a safe place away from their parents because that's who they're often having issues with. We've all seen the attention issues, and they often multitask on virtual calls, et cetera. Access to appropriate care, especially due to insurance barriers, clinician shortage, which we have not spoken about in this yet, but I think, that's a very real challenge. But very often, and especially during the pandemic, children's mental health was highly impacted by the health of the parents. I mean, everybody went through a lot of turmoil, no childcare, no, at home schooling, things like that. So the ability for the parent to even recognize the children's needs above their own issues and then get them appropriate help, I think was really exacerbated during the pandemic. So again, I think that expanding that team care approach that we've all been talking about to the whole family is starting to be really important in addressing that.
Yeah, I would add, just like with COVID and its revelation of the inequities that exist across our society, this was also true for mental health, right? This is a long-standing problem that was brought to the fore by COVID, and to a lesser extent by the availability of digital therapeutics that have provided access that has just been sorely lacking. 3 years ago, when I was still a health system CEO and we had 55 mental health patients boarding in our emergency room every day, that wasn't a COVID-related thing, right? That was a total availability of provider capacity and all of those structural characteristics that led to all of that mental health illness within the population. So just since the onset of COVID, VC funds have plowed more than $3 billion into mental health digital startups. Now, even for all of us, I would guess that's real money. And there simply aren't enough providers to care for everyone with mental health needs. And finding new ways, recognizing that digital's not some magic, but we've got to find new ways to provide support, because we know that communities of color are differentially impacted. 48% of non-Hispanic Black adults, 46% of Hispanic or Latino adults reported symptoms of anxiety or depressive disorder during the pandemic, according to the Kaiser Family Foundation. And so we've got to keep evolving this. To Linda's point about holistic, I'm now seeing companies tailoring their interventions to specific subpopulations like Latino or African American or what have you. We got a lot of work to do, and it's a big challenge.
Let me just link what Linda said with what Ron said. I don't know anybody that thinks this mental health challenge is going to be met by having more humans do mental health. So try to figure out the analytic underpinnings of figuring out who can be helped by what level of intensity, and therefore level of expense or level of engagement virtually or physically is a critical task, because we're not going to use behavioral, cognitive behavioral therapy for someone with serious mental illness. On the other hand, we're not going to use in-person psychiatry resources for someone who has relatively minor transient depressive symptoms. And so being able to we were just trying to figure out how to integrate behavioral and physical health before COVID hit. So now we have this explosion of virtual behavioral health, and we've really got no idea how to integrate that into virtual or physical virtual or in-person physical health. So trying to use analytics to direct the right level of resources to the need is a really critically important problem here, because we're just not going to have psychiatrists enough, or psychologists, or masters trained social workers to deal with every kind of behavioral health need that we've got.
When we apply the equity lens to this, right? It's like, if we look at this data, you know, Mark, I'm going back to your prior comment, to find the metric, slice it by demographic and background, and then you know what you can do. Linda, one piece is this report itself doesn't have the racial or demographic backgrounds, and there's a reason why. I'd love for you to share that. Is the data? Yeah, where is the data, Linda, on that one?
Yeah, yeah, you're right. It doesn't include a breakdown by race, ethnicity, socioeconomic status, or SDOH, because the data wasn't consistently available on the population to do that level of analysis, right? You couldn't drill down to that level. And that's part of the problem. I think there was a recent consortium health plan equity panel that said that Blues plans have less than 50% of data on race for their commercial members. So how do you understand health equity gaps or the impact of programming if you either haven't collected the data, don't have access to it, or it's missing for huge parts of your population? I know some people, like, they'll apply zip code level census data, but again, that can lead to assumptions that can contribute to further inequities. So that's one of the reasons why we now provide SDOH data at the individual level, so that we can start to measure this, supplement what's available from our customers, because data collection should not be yet another barrier to equity.
So the takeaway here is it's, I mean, we are collecting, most of these systems have really good, they go to the links on the claim side, on the clinical side, but if they don't include these measures in them, there's no way you can expect from our analytical tools to help us on this front, right? And so there's a bit of work we've got to do this year, Linda, to help fill in those gaps. Rishi, I know you and your team deal with this too.
Yeah, I think so. I'll just echo, I think Linda's really great point there. And also note that what we're seeing is that there is some variety in terms of the lines of business, Medicaid versus commercial versus Medicare, and the rates of the availability of race, ethnicity, and language data. So we work with some health plans, especially that have a sizable Medicaid side, and there's actually quite a bit of data that they already have and have been collecting, partly because of the public payer kind of requirements and some of the burden that they've already addressed in the past. So part of the story may be just the catch up for the commercial plans to kind of improve their data collection when it comes to race, ethnicity, while also trying to raise the floor for everybody. And I think it's a yes and. I do think that we've seen some great examples of how health systems can take a pass at being able to take the existing data that they have on race, ethnicity, language, along with other demographic variables, including social risk, and start to stratify and then target improvement efforts to close inequities, while in parallel also creating a quality improvement effort specifically that tries to improve that. There's an example of that we just came across of folks at UC San Diego that took an abysmal data collection rate, I mean in the low teens when it came to race, ethnicity, language, and within 2 years got that up to about a 90% because of focused, intentional efforts to be able to collect race, ethnicity data, especially direct data, which obviously has a lot more value as a gold standard compared to the indirect methods that a lot of plans use. So I think it's a really important point to plus one here, that data collection is foundational. Without the data, we can't really make sure that we're really being good at identifying hidden patterns of inequity.
I think that's another reason why it's important to link this to quality, because there's some sensitivity around the collection of this data. What are you going to do with it? There's enough history for people to be a little antsy about what are you doing with this? And so being able to say, we're trying to collect this because we need to make sure that everyone's getting high quality care, and we can't do that unless we know who's who. It's also worth pointing out there's some work going on trying to figure out how you ask these questions in common and comparable ways, because if we're going to do SDOH and the Department of Agriculture and Housing and Urban Development and the Department of Justice are asking these questions in different ways, then it's even more difficult to kind of figure out how you put these worlds together. So there's work to be done on both standardizing the collection, as Rishi says, helping people understand in practice how you ask these questions in a way that actually gets answers from people.
And Mark, just to that last point, I think the key thing I want to just elevate up here is that it's self-identified information, right? It's not staff making assumptions about racial or ethnic or linguistic identities of people. It's creating, Mark, to your point, providing the support, the resources, and the improvement framework to say, well, there are ways to be able to train staff about how to empathically and effectively ask these questions for people to self-identify. And that standardization, Mark, to your point, I imagine you're tracking with like the OMB categories, right? There already is a standard. So for folks who might throw their hands up in the air to say, this is too much, where do I start? The good news is that there are actually evolving standards and our existing standards right now that we just have to rise to and endorse rather than create from scratch.
Mm-hmm. Mark, you did some work with what Health Evolution Forum specifically. I just remember the collection of data being sort of the tip of the iceberg, if you will. Were there any other insights that came from that work? You're on mute.
I'm going to send people a link to that work. And there is a health equity pledge that includes a bunch of plans, employers, hospital systems, and others specifically around collecting and analyzing and using this data. And there's kind of a learning lab about how to, as Rishi said, how to ask the questions in ways that you can get answers. So I'll link to that.
Yeah, and I would just add, Linda, appreciating your point about the challenges of using zip code or zip code level analysis. I will say that that's something we did do as a health system because we didn't have other data, and it was highly revealing, even though it's not perfect, right? So sometimes perfect's the enemy of the good, and if you don't have the data or while you're gearing up to collect it, I would add, zip code, sub-zip code level analysis as one of the other sorting features to Mark's quality reports. You don't conclude definitively, but it opens up questions that you can then drill down into.
Mm-hmm.
Rishi, you should probably share that with everybody. I put a link to the Health Evolution work, and Rishi was sharing the AMA steps forward with not just us, but everybody.
Thanks, Mark. Shared it with the wrong group there. Yeah, there it is, everybody. Thanks for that. It's a link actually to some of these steps that Ryan, you've been summarizing so nicely this conversation. There are some of the steps that we've been touching upon, and this is also great validation for some of the things that are in that resource, right? Just ways to start concretely. At a later point, if there's time, I'd love to just share an example. One of the common kind of pushback, potential pushbacks that people get concerned about when doing this work is, well, is there some sort of reverse discrimination happening here, or does this kind of lower expectations or lower the focus for non-Black or essentially white patients? It's something that comes up, and it's an important thing as a leader to be able to know how to understand the data, understand what this means. And the good news, the great news is that equity is effective. And it's effective not only at improving outcomes for those who've historically been suffering inequities, but it's also beneficial for everybody, right? Inequity is a self-defeating form of exclusion. It actually harms everybody, particularly those who are harmed because of racism, et cetera. But there are some studies that actually show how you could do concrete quality improvement efforts to, for example, in cancer treatment, and I'll put a link in here for a wonderful case study of 5 cancer centers across the US that showed that an equity-focused QI effort that went through some of the steps that Mark and Ron have been talking about can lead to not only reductions or elimination of the equity gaps, but also overall improvements in outcomes for white and Black patients. In other words, equity is effective at improving overall outcomes and not just closing gaps.
Yeah, it's important to remember, just because you're rich doesn't mean you get good quality care. Just because you go to some center that's famous doesn't mean that you get good quality care. Most of us who are doctors have patients, have friends, have family who say, oh, I've got X, I've got Y, where should I go? And the answer usually is, I can tell you who's famous, but I can't tell you who's good. And so again, putting this equity issue squarely in the rooms of quality, as Rishi said, generally has the outcome of raising all boats here.
It really does. There was a question that kind of came in the chat that seems topical, so I just want to quickly ask it. Is CMS no longer shares race and ethnicity data with payers, so our analysis ability is limited? Do we know anyone that's doing advocacy to change that? And do we have thoughts on the value on not providing that? Does that ring a bell for anybody? Take just one person to take it.
Rishi?
Sorry, I was busy putting stuff in the chat. What was that again? Sorry.
CMS not sharing race and ethnicity data anymore with payers. Do you
Ah.
know anyone trying to advocate to change that? Was there a good reason not to do that?
Yeah, I need some more information about that. So I don't want to venture in. Maybe that the respondent can add some more context. Is it with specific Medicare and Medicaid data? Mark, have you come across this? Yeah.
If that person can, ask more questions in the chat, we'll try to take it. Medicare data.
Yeah, my understanding. I need to do some more digging on this. Particularly, I think that some of the push has been. This is Jesse, if I'm reading your question right. It's you're saying that CMS is not disclosing race ethnicity information for Medicare beneficiaries with plans, Medicare Advantage plans. Yeah, that would be bad.
I think, Jesse, maybe there's the collective feeling that there has to be work done here to advocate it for. I don't think anybody in this panel would say it's a good reason that they're not sharing it, because then you can't do these kinds of slicing and questions. I'm looking at the clock with 10 more minutes left. I do want to hit on one quick button topic on algorithms really quick. There was a article that I think most everyone read in the New York Times about an Optum algorithm prioritizing healthier white patients over every other category. And how do we prevent that from happening? Linda, I see your hand. Linda, how do we prevent that from happening?
Well, we have a lot of lively discussions, as you can imagine, with our co-founder, Dr. Nigam Shah, as well as with our customers on the topic of ethical AI. Again, the pipeline of data that our algorithms are trained on is coming from this inequitable access. So there's going to be inherent bias in the data that the algorithms will learn. So we need to understand if there are systematic differences in the performance of our models for certain subgroups, i.e., do we get a better predictive value for whites versus blacks or Latinos, et cetera. We also have to understand if there are systematic differences in the accrual of benefits for certain groups. So the accrual of benefits are functions of policy, right? How do you apply an intervention, or what action is triggered based on the model's output? So the example that you cited is just that, right? Care was prioritized based on the algorithm's output, which performs better for whites than blacks. So we could do a bunch of mathematical gimmickry, as Nigam calls it, to try to fix the performance bias. But that won't fix the accrual or application benefit bias. You can't do that with mathematical gimmickry. And in fact, if you try, you may exacerbate the inequalities by fair washing. So some of the examples I think, Mark, that you were referring to. So we do need additional data. We need to overlay this to make the disparities of those differences in performance, glaringly obvious, right? And then we can find the bias that can be found, because it'll be brought to life and we can take the appropriate action. So again, I think there's two different types of bias that exist. And again, the data has inherent bias. So you have to be super careful about what data you're using, how you're using it, and then how you apply the knowledge of that.
Yeah, I would add to that, that this is just a really important topic. The concept of hardwiring all of these biases into, algorithms that'll live forever. I think Linda's points are good ones. It's certainly a topic that I've been spending some time on at General Catalyst, where I'm an executive in residence. And, we frame this as a topic of responsible innovation. And a colleague of mine, Hamant Taneja, has recently written a book, Intended Consequences. It really talks about that the output of models, whether they're algorithms predicting utilization or other kinds of things, or what have you, leads to intended outcomes. And so he argues that developing these tools requires a mindset of, number one, an intention to do good and avoid harm. And that has to be augmented and ensured through what are called key consequence indicators. So we have to look ahead of time for consequences of unintended outcomes, or in this case, intended outcomes, because that's what the models were designed to do. So the great news is that social do-good businesses that are actively addressing issues of inequality or climate change or other kinds of things can generate outsized returns. So it's not, you just have to do good and be pleased with your efforts. You can also do good and generate returns. But if you don't design it in and have a process for measuring those consequences, you'll never find them.
Yeah, I'll just briefly kind of touch on that and underscore. I think it's, Ronnie, you put your finger on it, right? It's a topic that needs a lot of intentional focus right now. And Linda, some of the cautionary notes you put out there, right? The need to avoid the gimmickry, right? To try to control away for, or to try to like correct for the intrinsic bias, it doesn't make sense either. I do think that it is the job of those who design and also those who use algorithms to understand bias and also have a very intentional focus on reducing inequities. This is tied to, for example, what we understand and many organizations are going through right now, just understanding what racism is and therefore how to be anti-racist. It's a very similar kind of analog here. What does it mean to understand algorithms, understand how bias is represented in them, especially when the ground truth that they're trying to, or this concept of ground truth accuracy is a common concept, I guess, in algorithms. If the ground truth itself, if the historical data you're drawing from comes from a ground truth that is inherently discriminatory and structurally racist, then instead of controlling away for it, trying to kind of do some gimmickry, I think, Linda, to your point, it's about being very, very transparent and engaging in conversations so that people understand that bias is a factor. And then, and I think it's even more specifically important for those who, as we present for Realize and others who are in this business of providing these insights, powered by powerful algorithms, how to provide those algorithms and those insights in context and dedicate the time and the resources to identify issues of fairness, of bias, of discrimination, and as importantly, to also come to the table ready to discuss steps for remediation. Providing insights without kind of an understanding of the bias and therefore also tips about how to remediate can itself be injurious, right? Because people might come in and say, well, the algorithm told me so, and so I'm just going to go to town. So I think there's some steps to be taken, and one of the concrete steps is audits. The ability to kind of audit on a regular basis and to identify roots or potential areas of bias is, I think, it's going to be a key part of the quality assurance that I'm hoping more and more sophisticated consumers and customers, right, are looking for, and more importantly, more and more rigorous and ethical vendors like Realize can provide to say, we not only provide you algorithms, but we provide evidence of the audits that we've taken to be able to identify where bias may play a role and also how we can take steps to remediate them.
Thank you, Rishi. The thing that's happened throughout this conversation, I think we've peppered a set of actionable things folks from the payer community can take, folks from the provider community can take. But really, to wrap, I do want to give everyone one more chance to share what tangible actions leaders can take to address this issue. And it might be repeating a point you shared earlier in a succinct fashion, but really, what's the takeaway from this conversation? And I'll let whoever unmutes first go first. Ron, I saw you got the quickest straw.
Yeah, it's like I've been practicing for Jeopardy. So no, I think, there's just a couple of take-home points that are really important, in some ways feel simplistic. One, start where you can, right? Mark's point about what do you care about? What are you measuring? What's deemed to be important? Take another cut of that by these various factors. The second thing is begin collecting data if you don't have the data available so that you can use it later, right? It's not an either or 0-1. Link this to quality and to business performance, because this isn't just for social good, although that's a really important part of why we're doing it. And then keep these issues of structural inequity, structural racism in mind as explanatory factors, both with respect to bias and with respect to action.
I'll make 2 points quickly. One is, as Ron said, start where you can. I mean, Rishi and others have led the charge on helping us understand social determinants. But every time I see a hospital that has a farmer's market, but hasn't analyzed its readmission rates by race, I say, that's a little performative. Look at your net promoter scores by sex. Look at your outcomes by principal language. So it's important to have this broader understanding, but it's also important to do the stuff that you have control over. The other point I'd make is that everybody can start someplace. It's within our control to do it, and it's important to get started wherever you can.
Yeah, health is personal. It's not one size fits all. So, the ability to measure at the population level in communities, whether it's at the zip code, because that's the data you have, but then getting down to the member level to really figure out how to meet them where they are. But looking at those various circumstances as you can, not just checking the box, as Mark says, on we got a food program, so we're good. There are lots of other kinds of things you can continue to layer in. To meet, to use insights to target members, drive engagement, et cetera. But you really need to collect the feedback loop that allows you to assess whether it's working.
Yeah, I'll plus one and say, I think, starting where you can is maybe the tattoo I'll get tomorrow. And I'll just say that starting where you can includes quality safety, it includes population health management, it includes HR, it includes in other words, it's not just hiring a particular, a really key cautionary note is don't hire a person to do your equity work. Recognize that everybody has to actually start where they can. And when you're doing that, a key step to take is to make sure that people are swapping notes and coming together in structured ways to be able to make sure that as they start where they can, they're also coming together and finding efficiencies about how to take their work and accelerate that. How can the quality safety department and the community benefits department and the HR department now swap notes and realize that they have common interests, et cetera, et cetera. There's ways to be able to create efficiencies and more progress in a shorter amount of time by starting where you can and making sure people understand that every department needs to find a platform to come together to ask these critical questions together.
Thank you, Rishi. There's a powerful question in the Q&A around structural racism as it occurs in the patient experience. And the questioner is asking, how do we approach that? How do we address those kinds of challenges?
Yeah, I can take a quick pass at it, but underscore that a quick pass is not the approach to take, right, when doing this. So a quick pass at an answer, but I think there's two things. Everything we've been talking about is about how to recognize that one need not start with a whole transformational process in your organization to be able to start where you can, right? The yes and answer here, though, is that operationalizing a commitment to equity is key, organizing and operationalizing. And it's important to also, for leaders especially, to recognize that while that work is happening, you need to normalize, understand what racism is, understand what the commitment to racism, anti-racism really means, understand what structural racism looks like at the ground level. Those are conversations that need a space to develop outside of just the quality improvement team or just the teams. So normalizing understanding of structural racism is as important as operationalizing a commitment manifest through concrete team data-driven kind of projects. And by doing that, then you can create spaces for the dialogue. There are examples of vanguard institutions like the Southern Jamaica Plain Health Center, health systems like Cone Health System that 5 or 6 years ago actually acknowledged its own role in institutionalized racism in the past and has actually been taking concerted efforts to try to not just provide redress, but to showcase what equity looks like. There are concrete steps that are out there that the vanguards can teach us about how to understand what structural racism manifests, how it manifests at the individual level. And part of that can be as simple as a question like this in a patient room. I understand that some patients may have experienced racism in past interactions with healthcare. Is there anything about your experience you want to share with me? In other words, there are ways that we can take these heady concepts and then learn how to through a structured, intentional process, start to have conversations that might be really straightforward conversations to be able to understand these issues. There's a lot of wonderful scholars who've been writing about this, especially scholars of color, around what structural racism looks like at the individual level. Kamara Jones being chief among them, I would say.
Thank you, Rishi. I want to thank everybody, Linda, Mark, Ron, Rishi, everyone who is here with us live, as well as those who are watching this later as well, for participating in this conversation. The perspectives that we shared are our points of view, but we also do want to hear from you as well on this issue. This is a issue that is never complete, right? The path towards a more equitable healthcare system is one that we will be fighting for quite some time. But with that note, I do want to thank everybody and hope you have a wonderful rest of the afternoon or evening. So thank you.
All right. Happy Valentine's Day.
Yes, happy Valentine's Day.
Thank you.